turn damage, are they going to get sued, right? They're going to identify it, treat it, and then punt you to everybody because they're ADD, right? Follow up with your PCM, follow up with hematology. Pulmonary is going to look at it from a different standpoint too, right? They're going to get really into the VQ scans and VQ mismatch and all other stuff. Hematology, what do you think they're going to focus on? They're going to nerd out and run a bunch of labs and see if there's some underlying hereditary disorder, right? So we can kind of break this down and see either hereditary, there's a genetic predisposition, or acquired, right? And we kind of talked about the acquired, like classic DVT, Burkitt's triad. So abnormalities in the coagulation of natural anticoagulation molecules that increase risk of VTE. Identified greater than 50% of patients with VTE who are without obvious reasons, right? So if they don't meet that Burkitt's triad, can't really explain it, we're thinking hereditary. Commonly associated with cardiovascular disease and obstetric complications. So if we look at here the most prevalent examples, we think about our clotting cascade, there's kind of two mechanisms in there, right? There's brakes and accelerators. We think about antithrombin, protein C, protein A, these are the brakes. So if they're deficient or something's going on with them, the clotting just kind of continues and it goes rampant. Versus this mutation, which makes these brakes not relevant, right? So if you look at these deficiencies, these brakes, right? They're the things that are slowing down or stopping the clotting cascade. They're kind of in order of strength. So antithrombin, that is the master brake, right? That's what's stopping thrombin in the common pathway. And then protein C, and then protein S is more of a cofactor of protein C, it helps it. So where are all these made? Liver, right? So it comes back to liver. If there's something going on with the liver, it can impact this stuff, right? If they have liver disease, liver injury, so kind of always draw that back is if there's an issue with that, vitamin K dependent factors, it could be something going on with the liver. Factor V, light mutations, most common of the hereditary thrombophilias. That's going to be part of the common pathway that is an accelerant. So if you think about it's an accelerant, that'll speed up. You can still have clotting without the factor V, but if there's a mutation that's stopping these other brakes, now you're just accelerating the process and they are more faster and more prevalent to get a clot. Prothrombin gene mutations, the same thing, right? Ultimately, the master regulator, the master part of the clotting cascade is thrombin. That's what it's all about. So this prothrombin is what converts into thrombin. And then antiphospholipid syndrome, we'll talk about that. That one's commonly associated with miscarriage and obstetrics. So think clots and miscarriages for that one. And then I would say Roberto Cole would love this slide right here. Know these testing, when to consider testing, right? This is what hematology cares about. That's really why you're consulting them. You don't need hematology just to be able to start an anticoagulant and start breaking down a clot. They're your friend is when you have that patient that doesn't meet the Burkitt's triad, or they're having unprovoked, or they're not responding to your anticoagulants, or they're having adverse reactions to those anticoagulants. That's who we care about. Hematology is going to step in. So positive family history, that's identifiable. Like they tell me specifically, like my mother, father, brother, and sister have factor V, Leiden mutation, right? Strong family histories, maybe they don't have a specific clue or a specific diagnosis, but they can say, yeah, my mom said she got clots with me after she had me in the hospital. My dad's had them multiple times, but nobody ever really identifies it. And then first VTE before age 50, right? They may be recurrent, right? They've been worked up, they've been treated, they completed their initial treatment, and they got another VT of some sort. That would be indication for this testing. VTE, specifically an unusual spot, right? Mesenteric artery, those are rare. So if they have that, and they had to have surgery for this very unique kind of clot, then that could be considered. Warfarin-induced skin necrosis, which we'll talk more about, and then multiple miscarriages. Yeah. Yeah, an unusual spot. Sorry, I'll have to correct that. Good call. All right, so multiple miscarriages. I want you to think this antiphospholipid syndrome until proven otherwise. You see multiple miscarriages and a history of clots. We're thinking this. Right, hereditary thrombophilia. I made a few changes to kind of expand on and clarify. I'll point them out as we go. So protein C deficiency and warfarin skin necrosis, right? So we've talked about protein C. We think of that as a brake, right? That inhibits the factors 2 or 5 and 8. 5 is that Leiden, that's the common pathway. And then 8, where's that at? Intrinsic pathway. It's the last step in the intrinsic pathway that leads into the common pathway, right? So this can impact on multiple levels. This can impact the intrinsic and the common pathways. Why that happens is you give warfarin, they have protein C deficiency. Warfarin initially lowers protein C, increasing clot risk. So I added this to kind of clarify. Warfarin blocks the liver's ability to produce all new vitamin K dependent proteins. It doesn't impact the circulating factors that are already in the bloodstream. So it's stopping the creation of new ones. So you still have these circulating factors in there, right? And what we talked about with warfarin, can I just initiate warfarin by itself? What do I usually do with warfarin for the first 5 to 7 days? Heparin bridge, right? So heparin is instantaneous. And what heparin does is it basically boosts up antithrombin. Whereas warfarin, it takes days, it has a longer half-life, it's an oral tablet, and it depletes these vitamin K. So factors 2, 7, 9, and 10, right? The factors for actually clotting, and then protein C's and S, right? So without that C and S initially, we have factor 2, that prothrombin that turns into 2A, which is thrombin. It's still going wild because it has a longer half-life. So it's kind of doing it uneven. So recurrent VTEs, skin necrosis after warfarin initiation. Now I'll have some pictures here. It's a pretty drastic presentation. This isn't something you're going to miss if you're on a hospital ward and you see it. How we're going to make our diagnosis? Functional protein C levels. And typically with this one, it's a clinical diagnosis. History of warfarin. I'm thinking that there's some deficiency in either protein C or S, or I didn't do a heparin bridge. I'm going to stop the warfarin and switch to another anticoagulant, heparin or DOAC. What would be some contraindications to DOAC? So severe renal disease, what else? Pregnancy or breastfeeding? So any type of artificial heart valves would be a contraindication, and then moderate to severe mitral stenosis would be also. Those are the kind of the 4 big ones when we think about it. For our testing purposes, no DOAC or heparin. I'm not going to go any further than that, right? I'm going to keep it at just the class of the medication. And some of these, if you start seeing like 2nd, 3rd order meds, I want you to focus on first line therapies for testing purposes, right? We're not hematologists, oncologists, we're primary care. We need to have a high index of suspicion. Know we're going to start it off with. If that's not working, then we're going to kick it off. We'll get somebody else smarter to help us out, right? So VT prevention, avoid conditions that increase thrombotic risk, right? What would be some of those conditions? Stasis, right? So long flights, long travel without moving, surgery, stuff like that. Anything that's going to put stress in the system. Judicious use of prophylactic anticoagulation. Typically, you're going to identify these patients, and then later on, as they're getting like their surgery workup, it'll be identified, hey, I have this risk. Anesthesia will identify surgery, and then they'll come up with a plan of attack of how they're going to do that. Either we're going to start this medication a week in advance, or we're going to initiate it as soon as surgery is over, depending on the surgery. And then prophylactic protein C concentrate predominantly are before and post peripartum. So protein S deficiency, these are all going to be the same. Protein S enhances protein C. So protein C is that bigger break. Protein C can work without protein S, but it doesn't work as efficient. Protein S will work to a degree on its own without protein C, but protein C is really the major one, and the protein S is helping that. So same concept, deficiency leads to clotting. It has a shorter half-life than factor 2, that prothrombin. We're going to diagnose this with functional protein S levels, and it's typically the same kind of management as we would for protein C. And this one specifically, though, we're going to avoid oral contraceptives. So this is a discussion you have with the patient. You include OB. in hematology to come up with a plan of attack. Maybe it's an IUD or some type of non-pharmacological contraceptive. So warfarin-induced skin necrosis, right? It's the same thing. We've given warfarin in a patient with protein C or S deficiency. Warfarin blocks the production of new vitamin K-dependent coag factors, protein C and S. And then C and S have the shortest half-life, so a matter of hours versus factor 2. And again, this is impacting warfarin stopping the creation of new clotting factors or new vitamin K-dependent proteins. It's not doing anything to what's circulating in the body. And it takes a while for it to kick in and come to effect, so we have to have that bridge. So clinical presentation, development of demarcated areas of purpura and necrosis due to vascular occlusion, skin necrosis after warfarin initiation, right? So the history is going to be very specific. They were given warfarin. Either they have a deficiency or heparin wasn't started. And so now you're going to start getting these purpura and necrosis. So if it's not working, we're going to stop our warfarin, switch to an alternate anticoagulant, and then administer vitamin K. And I changed this. Always going to administer vitamin K because why? That's the reversal agent for warfarin, right? And then it's either you're going to also add protein C concentrate or FFP, right? FFP will have protein C in it, but maybe we don't want to, they don't need all those other factors and all other stuff, so we're going to give them straight protein C concentrate. So vitamin K plus protein C or FFP. And here's what this looks like. So this would be kind of in a hospital, this picture on the left. It's a very drastic presentation. And then this is going to be the healing process as it goes. And then this is going to be probably months later, and this is going to be weeks later. So they're going to have a long duration required wound management. So I will say as a PA profession, if you can stomach this stuff and you get good with it and you learn the concept, then you can make a killing doing wound care. You get into like hyperbaric medicine, wound vacs, all that stuff. A lot of it requires you to do like home health care, go to people's houses. If you don't mind driving for miles on your car, great work-life balance and great money. All right, antithrombin deficiency. So again, antithrombin, this is kind of the master break of the clotting cascade. I added this to clarify. So protein C, protein S are also breaks. Antithrombin is the master break, right? That's really what's going to stop the clotting cascade. Inhibits thrombin at factor 2 and then factor 10. Where's factor 10? Common pathway, right? That's where the intrinsic and the extrinsic come together. That's the first step in that common pathway. So deficiency increases clot risk, inherited or acquired. This is going to be that recurrent DVT or PE. We're going to do an antithrombin activity assay, and then anticoagulation, antithrombin concentrate. So just look at your vignette, right? If they say initiate warfarin, take those protein C, protein S. This one is more so you can initiate warfarin, but it's not necessarily going to impact it. Factor V Leiden mutation, this is part of that common pathway. It's the most common inherent blood clotting disorder. So this mutation makes it resistant to degradation by protein C. Protein C is that break. So essentially this factor V says, I don't care protein C, and it keeps doing what it's doing in the clotting cascade. So recurrent DVT, often provoked by a trigger. This can also be induced with pregnancy. With the other one, that antiphospholipid we talked about, that's more associated with miscarriages, versus this is more so going to impact the mother when she's pregnant or gives birth. Genetic testing for factor V Leiden mutation, and then anticoagulation for significant events. This is the exception of certain high-risk situations such as surgery, pregnancy, or postpartum. Not everybody with factor V Leiden mutation has to stay on lifelong anticoagulants, but if you've identified it and you know they're going to have some event that puts an increased risk for a clot, that's when we're going to likely initiate our anticoagulation. It's prophylactic for that. All right, prothrombin. So this is that factor 2 in the common pathway. We just talked about the antithrombin deficiency. So this is the exact opposite. This is a mutated prothrombin, so it's going to increase the thrombin, which is what the master regulator of the clotting cascade. So unprovoked VTE, this one you're going to do genetic testing for, and then anticoagulation based on the risk, event risk, so surgery, travel, anything along those lines, pregnancy. So antiphospholipid APL syndrome, or APS, right? This is an autoimmune, so there's going to be some type of autoimmune disorder underlying it, right? That's an important, kind of the two diagnostic criteria. It's either going to be unprovoked clots, frequent miscarriage, and then there's some type of autoimmune disorder going on with it, right? So this one, think venous clots and think miscarriages, if you're seeing that vignette. This is basically making that blood stickier. These things are not being able to, these phospholipids on top of the surface membranes are promoting thrombus because they're not picking up factors correctly, and they can pick up more factors than necessary or not enough factors, so it can change the process. But think DVT, PE, multiple or recurrent miscarriages, including multiple embryonic losses, less than 10 weeks gestation, fetal death after 10 weeks gestation, and premature birth due to severe preeclampsia. Key to diagnosis is you have to have positive antibodies on 2 occasions, 12 weeks apart. All right, 12 weeks apart is key for this one. 2 separate occasions, 12 weeks apart. And then management is anticoagulation, warfarin. Our goal when we start warfarin is an INR of 2 and 3. And avoid DOACs for arterial events and low-dose aspirin, right? So warfarin, again, we've talked about, it's a tablet, dirt cheap, so you're still going to see it, especially in rural medicine or people without insurance coverage. Even though DOACs have become more popular because they don't require testing, they're safer, more stable, they're significantly more expensive. So if you're working on the economy, sometimes you have to sell it to an insurance company of why they need a DOAC versus warfarin. Kind of the sales pitch I always had was, well, the person lives in rural, they don't have the ability to go get labs on a routine basis. And if they're going to stay on anticoagulants long-term, kind of DOACs may eventually save the price differentiation because they're not getting frequent lab evaluation. They're less likely to have side effects. So that's kind of why I would push DOAC or my sales pitch to somebody. Here's a chart breaking that down and kind of talking about it. All right, acquired thrombophilia, right? We talked about this. This is your DVTs, PEs. So being nice, so Wells criteria, you don't need to memorize it. There's not going to be a question saying calculate Wells criteria. I'm either going to say high, low, 4, less than 4, higher than 4. So if I say higher than 4, what's that telling you? There's a high incidence or high likelihood that they have it. So if I'm going down the PE pipeline, if I say over 4, what am I trying to get you towards? CTPA, right? And if they can't do CTPA because of 3 reasons, what are those 3 reasons? Pregnancy, renal disease, and contrast allergy or contrast sensitivity. What would be indications of renal disease? GFR, what else? Elevated BUN, elevated creatinine, right? So critical thinking, it's not going to say renal disease. You have to start putting all this stuff together. All right, we talked about liver disease. Liver impacts everything, right? What else does the liver do? Both pro and anticoagulation factors, what else does the liver do for us? Yeah, TPO, which is what?
Platelets.
What?
Making platelets.
Yeah, platelets. What else can the liver do for us? Yeah, it can start producing EPO if the kidneys aren't doing its effects. The liver is very important. It also can help us create RBCs and those other blood cells that the bone marrow can't. So if you think liver disease, what would be some indications of liver disease? Chronic alcoholic, what else?
Hepatitis B.
Hepatitis in general, right? I had a sergeant major on his R&R, went down to Mexico, ate street tacos, and he got hepatitis. So, and it was a kinetic environment, like that deployment in Afghanistan, like that brigade lost a lot of people, and he got sick as shit coming back from Mexico on his R&R. Not the happiest guy. So, hepatitis, what kind of labs would we expect to see with liver disease? All right, let's look at the clinical presentation. What would a patient with liver disease look like?
Jaundice.
Jaundice, okay. ascites, all that free fluid in the abdomen. It looks like they're pregnant and they're a man. What else? Bleeding, right? Easy bruising. A number of things that can cause that. They could also just have an enlarged liver as well, too, right? That's the one where you actually measure it, because you learned that in sophomore, and none of y'all have done it since then, right? Has anybody done that on their OSCE? Anybody bring out a tape measure and be like, do that? No. So this will be that one where you actually do it and you're like, oh shit, this actually comes in handy right now. Right? So impaired hepatic production of those inhibitors of coagulation, protein C, protein S, antithrombin, right? Those are the brakes in the clotting cascade. That's what stops or slows down the clotting. But it also can impact our platelets and everything else too. So varices, portal vein thrombosis, jaundice, bruising, mucosal bleeding, GI bleeding, right? Pretty common. The diagnosis is going to be increased PTINR, decreased platelets, decreased fibrinogen. Makes sense, right? They're not having this clotting factor or the brakes, so their bleeding is going to increase. They don't have platelets because TPO is not being made, and then they don't have fibrinogen, so they can't make these clots. So ultimately, we always want to treat that underlying liver disease if we can, or liver transplantation if they're a wealthy physician. They don't want to quit drinking, and they can get liver transplants. All right, remember Burko's triad, right? Stasis. What's an example of stasis? Kind of clinical vignette, like what would that look like?
Flying on a plane.
Flying on a plane,
Or
Stuck in a bed.
hospitalized for a while.
stuck in a bed after surgery, somebody who's like home health care, right, or nursing home patient, something along those lines. Hypercoagulability, could be pregnancy, that could be an underlying hereditary disorder. What's that? Major surgery, some type of medication. And then vessel wall injury, right? That could be surgery, that could be an actual injury, that could be somebody getting hit in the leg, it could be a number of things. And typically we think about DVT turns into a PE. Do you have to have a DVT to get a PE? No, you don't. But the majority of patients with PE are probably going to have some clinical signs of a DVT before that. Risk factors, don't memorize it, just everything we've talked about, things that are increasing your risk. Pathophysiology, right? There's some type of endothelial injury, activation of that clotting cascade. So if there's endothelial injury, would this be intrinsic or extrinsic pathway? Intrinsic pathway, right? Because it's internal and it's slower, it has more steps, it's more complex. Extrinsic, it's external, it's very fast, but they're both still leading to the common pathway. So stasis and hypercoagulability promote clot formation, and then that can propagate or mobilize to the lungs and turns into a PE. Extremity pain, unilateral, usually calf swelling. You guys started your ultrasound stuff yet? No. All right, so when you do that, you'll be evaluating, and you guys will evaluate for DVTs. That'll be one of the testing criteria. And then Homan sign, low sensitivity, not really helps support your diagnosis, but if you don't have it, it's not going to be not necessary for diagnosis. Just like before, we're going to look at that Wells score, and like I said, high, low, greater than 4, less than 4 is what I'm looking for, right? Specifically for DVT, if it's low, we're going to do that D-dimer. If it's negative, that tells us what? There's no clot, right? If it's elevated, does that tell us there's a clot? No. No, it's just pointing in there, points in that direction. For this, compression ultrasound is going to be the gold standard, or what we're going to be focused on. Sonography is the gold standard, but rarely used. So think compression ultrasound, right? So if you have a high Wells score, we're going to skip the D-dimer, and we're going to go to that compression ultrasound, okay? Then hypercoagulable workup is, again, what class are we in? Hematology. So think about like a hematologist, they want this workup. So likely there's going to be like a panel. So if you go to like Genesis or whatever medical record you have and you look at your labs, it'll have a hypercoagulable workup or lab set, and it will have a lot of this stuff in there. Reserved for unprovoked DVT, young patients, or family history. So again, you're going to go back to that slide I told you that Roberto Cole loved. Understand it, right? VTE before the age of 50, positive family history or strong family history, along those lines. Anticoagulation is mainstay, mechanical interventions for selected cases, right? They may put that filter in there, vera vena cava. Not really a filter, it basically just breaks up that clot into smaller, more manageable pieces. So it's not necessarily trapping everything. But these filters aren't long-term either, so typically it's a temporary measure and then it's removed later on. There's your well score, don't need to memorize it. All right, so changes, I added those contraindications that we talked about on NOAC just so everybody knows them. Initial therapy is going to be heparin of some sort, and that's going to be our bridge for warfarin therapy, right? Direct oral anticoagulants with DOACs are preferred for convenience and decreased monitoring, but we're going to avoid them if they have any contraindications. And typically 3 to 6 month minimum. Extended therapy for unprovoked DVTs or persistent risk factors. Typically, this is going to be hematology dictating this minimum time frame, so you're going to consult them. Why you should care about this, right, is hematology is going to kind of drive the train, but you're still going to be managing the patient, right? Primary care, we're responsible for everything, so we have to know if there's contraindications, how long does patient stay on there, these medications, are we responsible for doing routine lab or the hematology? So you kind of have to level the bubbles and clarify with them what they expect of you. Special considerations, cancer-associated DVT, we're going to prefer low molecular weight initially. And then for pregnancy, again, low molecular weight, heparin preferred, no warfarin or DOACs for pregnancy. And then that bridging that we talked about, 5 days to deplete the existing vitamin K dependent clotting factors in the body, because warfarin just stops the creation of new vitamin K dependent clotting factors. It doesn't do anything about the current ones, so they have to kind of run their course and die off. But heparin or low molecular weight until therapeutic INR is achieved, and typically that INR we're looking for is 2 to 3. And then warfarin is the safest anticoagulant to administer in patients with chronic kidney disease. Again, so everybody's going to be pushing DOACs, talking about it, but there's still a lot of reasons why we care about warfarin. Heparin's not really realistic for long-term use because it requires IV or injections. It has a very short half-life, so it's frequent administration. Whereas warfarin is just a tablet, and it has a longer half-life, so they even have a little bit of room if they miss a dose. Pulmonary embolism. Now, the thrombus is embolized from the systemic veins to the pulmonary arteries. So it's putting pressure on the pulmonary vascular, which is then putting strain on the heart, especially the right side. So again, that right heart failure. And then we're having this mismatch of ventilation perfusion, right? Patient's still breathing in the trachea, air is still getting down there, but now part of that lung is not being able to actually recept or receive that blood. And so you have air mis-shunting now to the other side. That classic triad, dyspnea, pleuritic, chest pain, hemoptysis. What I always care about is if I have a patient in the ER with tachypnea that I can't explain, right? Sudden onset of tachypnea, I'm thinking PE until proven otherwise. All right, tachypnea, the ER until proven otherwise, I'm thinking of PE. The same thing as before, well score, I'm going to tell you high, low, greater than 4, less than 4. If it's less than 4, we're taking D-dimer, higher, that's CT angiogram, right? Can't do that because of one of these reasons, DQ scan. And then anticoagulation is mainstay, thrombolysis or embolectomy for select cases, very rare because anticoagulation is not going to do anything to the current clot, it's just going to prevent any further clotting. So that would be your indications if there's a giant clot that's causing some issues, we may do one of those procedures. Here's your Wells score again, you don't need to memorize it. Treatment is very similar to DVT, especially initial therapy and long-term therapy. Only kind of difference here now is these secondary treatments, thrombolysis, right, for that massive pulmonary embolism causing hemodynamic instability, right? Their heart is impacted, not being able to deal with that blood pushback. Or high-risk submissive, submassive PE, again, it's causing dysfunction of the heart, those elevated biomarkers. Embolectomy, very rare. surgical team that was attached to us in Iraq had to do one of these on a contractor. We should have known it when he showed up and he said, "Hey, how do I get a warfarin refill?" Like his contracting company sent him over there knowing that he was on warfarin, and he showed up to the aid station. He's like, "Hey, I just need to refill my warfarin," acting like it was no big deal. And I was like, "No, man, you need to get it out of here." So we contacted the contract company, and they were working on it, and they were in no rush. And the guy drew a little major clot, and the surgical team had to do an endolectomy on it. He survived, but it was very ugly. All right, any questions? All right, let's take 5, and then we'll kick off the next class.
Where is fixation at the end? I didn't know. So we're responsible. Yeah, do you want to bring that? You know, like when people bring like food and stuff. And then when you want to start to part of it. Does someone know you okay? That lady bought a $300 cake for me. She lives around Monday.
Oh no, she brought it back. It's out for me. I'll find it.
Southern. Like 2 hours from Chicago. 2 hours north. Yeah. But like, it's insane. Yeah, yeah. We're gonna get yours out. Yeah, of course. We're gonna be
Oh, so he only signed it. Oh, oh, right.
You're the one that keep going down. Be on like
I'm not gonna bring on any of the wells, but it's really
I didn't read.
Oh,
So I put MMF for therapeutic, so I just put therapeutic. And then I put you don't need to go deep, so like the top layer skin so it was there,
you did it.
I sat there and I was like, there's two questions that I like thought about, and I was like sitting there, I was like, over the trunk is the 78. I was like, so I was thinking limited versus diffuse. So I sat there for a minute, and then the other one, it's stupid. I was so good at it with the just the way he yeah. I got that one right because then he also said it too. He's like, he said we were asking questions from the back. He said what's I go? And I was like,
Oh,
no, no, he said. There was funny. There was some questions on there. Yeah, there wasn't a single answer that was like that. Yeah.
it's so like, like usually I'll just like look at other answers if I know right. And I was like,
We need to talk about that.
well, we didn't talk about it.
Or was it? That was like one. I was just sort of, I knew I needed to finish 60,000 hours, and I was like, I know I never finished. I was like, yeah, I'll finish.
Hey. Whoa, wow.
Wow.
Disrespect.
Wow, people. Wow, people.
Yes, we could go. It's just like the weird that they like here.
Right, let's get started on platelet disorders. All right, platelet disorders. Review. We've already talked about this due to death. Thrombopoiesis, creation of platelets in the bone marrow. Right, driven by TPO, which is produced in the liver. So low platelet count, increased TPO, which is also going to increase platelet production. Crucial role in hemostasis, right? So if liver is impacted, that TPO is going to be impacted. We're going to have decreased platelets. So kind of your initial approach to these. So if you have a CVC and you have thrombocytopenia, until proven otherwise with a blood smear, we're thinking pseudo thrombocytopenia, which where that laboratory artifact by that chemical that they put in there is going to cause this platelet clumping. So when the CBC looks at it, it's going to show an abnormally low platelet count. So now you can rule out pseudothrombocytopenia is to get a peripheral smear, and then that's going to show if there's actually platelets clumping or not. Then kind of two ways you can break down platelet disorders is quantitative, it's either too low or too high, or qualitative, something's actually going on with the platelet function, adhesion, aggregation, or secretion. So not necessarily the platelet itself, but something's causing the platelets not to function correctly. Then you don't have to know lab values. What I want you to look at is that CBC, see what's low, what's high, and go from there. Quantitative defects reduce survival, so it's that increased destruction. Immune thrombocytopenia, which we'll talk about, heparin-induced. TTP has hypersplenism, right? So they have that large spleen. The large spleen can kind of tell you a few different things, right? What could that tell you? Yeah, so spleen's working overtime in either one or two ways, right? It's either working overtime trying to compensate for bone marrow failure, it's trying to create more platelets, or something's causing it to work overtime because it's trying to process all these platelets and RBCs that it's destroying, right? So, spleens can get big. They can get to like 20 times plus the size of their regular size. They can get huge, like a football. Reduced production, so bone marrow disorders. What was a few that we talked about? We've talked about one specifically already. It causes pancytopenia. It's not cancer. Aplastic anemia, right? Pancytopenia. What's pancytopenia?
Low everything.
Everything's low, right? So there's three main cell lines. The RBCs, the white blood cells, and platelets. And what stem cell line do they come down from? The myeloid, right? So if we're seeing pancytopenia, what's the first thing we're thinking? Until proven otherwise. It's cancer. There's other things that can cause that, but we're thinking cancer until proven otherwise. Now, qualitative defects, why these are commonly overlooked is we get that CBC, right? We do a CBC for everything. You're anemic or you're feeling down, depressed, we get a CBC. If you're feeling fatigued, CBC. We get CBCs for everything, right? It's the most commonly ordered lab. So commonly we're going to see as well, platelets are down or they're elevated. If they're not, then we kind of move on to something else. Qualitative, we're not going to see that in our CBC. And we may not see that on our peripheral smear either, right? So this requires a little bit more working up or a higher index of suspicion that, hey, something could be going on with the platelets itself. Von Willebrand disease, we've talked about that. What does von Willebrand fracture do? What is its main purpose? Yeah, so it helps the platelets actually bind to each other and bind to that exposed vascular injury, right? So those little push out their arms, they start grabbing up more platelets, and they start attaching to the wall, and that's what allows us to create that platelet plug. So if we're deficient in that, we actually can't stop that initial bleeding after the vascular spasm. And then drug-induced platelet dysfunction, what would be that? Like, what's the most common? We actually prescribe it. Aspirin, right? What's another one that helps with platelet dysfunction specifically? Yeah. And then what's another one that we commonly prescribe for our young patients? Typically, they don't have an issue with it. Sometimes they do. NSAIDs in general, right? So Celebrex, meloxicam to a lesser degree, but typically any NSAID could cause these issues. Remember, what did Rasputin tell the Empress in Russia? Hey, don't do that. I'm going to spit on your kid. He'll be all good. I got you, girl. All right, immune thrombocytopenia. This is a very easy one to find on labs because there's one characteristic about it that you're going to see on the CBC. Right? Autobodies target the platelets and splenic destruction, right? Removed from circulation. So spleen's working overtime because they've been targeted and identified and said, hey, we want to get rid of these. So kind of broken down into primary or secondary. Primary is the most common, but we need to rule out any secondary causes first. So it's a diagnosis of exclusion. So we think autoimmune syndromes, autoantibodies make sense, right? Infection, right? Do they have some underlying infection that we're missing? Medications that's causing this, and that list is kind of extensive. Hematological malignancies, so lymphoma, leukemia is something that's affecting the bone marrow and its ability to create these cell lines. A lot of these patients are going to be asymptomatic. It's going to be an incidental finding, or their symptoms may be very mild. If we're thinking a child, right? Child has easy bruising, petechiae. They have a preceding viral illness. The parents may say, hey, they just got over a cold, or they had a cough, or something like that. That viral illness may not even been like really come up on the radar as anything significant. Mom gave Tylenol, the kids stayed home from school for a day, but nothing significant. That may be the trigger that initiates this ITP. Typical presentation, mucocutaneous bleeding, right? So what would that be? What would be common?
Gum bleeding.
Gum bleeding, right? Brushing their teeth, or maybe it's that 8-year-old who has a strong addiction for meth and he's not brushing his teeth and he has meth mouth, right? Petechial rash, right? That can be just about anywhere. Easy bruising, right? Kids just get bruises, but are they getting more likely? Are they getting them in abnormal places? You see a kid with a lot of bruising, what else are we thinking?
Abuse.
Abuse, right? You may be starting accusing the parents of them and like making them feel like shit, and then you just find out they have some genetic condition, and you're gonna feel bad now. So, plus or minus fatigue, right? Again, that's kind of a vague symptom that could be a symptom of just about anything, so you're putting that along with that easy bruising and bleeding. More advanced systemic symptoms is fever, anorexia, bone pain, GI neurosymptoms, splenomegaly. If I tell you fever, anorexia, bone pain, what else should you probably be thinking of your differential diagnosis? Cancer, right? Should prompt investigation for secondary cause of ITP, right? That should make your spidey senses go off if you're seeing a patient that's having bone pain, anorexia, and fever. So as platelet counts fall, so if we look on the left, this is kind of a slightly decreased, and then this would be significantly decreased. First times we're going to see is that dry purpura. Petechiae is going to be skin only, right? It's pretty advanced, this picture. And then mucous membranes, as they get moderately decreased, wet purpura. So nasal passages, buccal mucosa, gingiva, right? We talked about it. And that dentist that sent me a patient that said, hey, I'm not working on this guy. His gums are bleeding by me just touching him. We found all his petechiae in the roof of the mouth. So these are the patients that if you're seeing petechiae in other places, you actually need to open up their mouth, look in there, palpate, and put a light and look at the roof of their mouth. Underneath their tongue, you may be missing stuff. Then visceral, internal, this is rare, but life-threatening, like this is pretty much to be advanced. This isn't going to be an asymptomatic patient, likely going to be in the ER setting. Then kind of 3 different stages of this. Acute, we're thinking children, usually preceded by a viral illness. Majority of these, 80-85%, are going to resolve after about 10 days and not require any further treatment or intervention. Adults are going to be more of our persistent chronic, right? This is going to be that relapsing, remitting course. They've already been seen for this before, worked up, and it's coming back. And this is associated with our secondary causes. So how you identify this on labs? You need to think immune thrombocytopenia as if it's just isolated platelets are decreased, right? Isolated thrombocytopenia, I want you guys to think ITP until proven otherwise. If you get that in CBC, we are going down it. We're going to look at our RBCs, our white blood cells. The RBCs, we're going to look at our hemoglobin, hematocrit, that H and H. If those are all normal, then we're going to come down to that platelets. If that is decreased by itself, we're thinking ITP until proven otherwise. Typically on the peripheral smear, we're not going to see anything besides decreased platelets. That's all it's going to note, but there's not going to be anything abnormal about the platelets. They're not clotting to each other or clumping or anything like that. And the reticulocyte count typically going to be normal because this isn't impacting RBCs or anything else. It's just the platelets themselves. You may do a bone marrow biopsy. Typically it's not needed, but it may be if there's unexplained coexisting cytopenia, right? So now if I had decreased platelets, decreased white blood cells, or decreased RBCs, but not true pancytopenia, I may do a bone marrow biopsy to see if there's something else going on or if there's any functional issues with that bone marrow. Other labs, serological testing, right? That's going to be really for our autoimmune stuff, right? That could be one of the comments. So think adult autoimmune serological testing. This is an important slide to know because this is our management, right? What everybody's going to jump to is they're going to see decreased platelets and what? What do we do for decreased platelets? We're going to give them platelets, right? Not always the case. We can be a little patient with our patient, normalize it, right? So we're going to trend it. They may be admitted, we can trend those. But as long as they are no significant bleeding and that platelet count stays above 20 to 30,000, they can continue to be monitored, right? So look at your patient. If they're symptomatic and they have a low platelet count, we're going to give them platelets. If they're stable, asymptomatic, and they have low platelets above 20,000, we can monitor that patient. Right? And then monitoring should continue on platelet count is stabilized to 100,000. Right? So they may be discharged before then, and we're going to have them come in for serial exams, and we're going to keep getting CBCs on them. And then we're going to continue to monitor until they're 100,000. So again, I want you to focus on first-line therapies. Typically, the primary care setting before they get to hematology, we're going to be doing steroids. It's going to be our first treatment. IVIG, if they're having severe ITP, this is the gold standard, IVIG for severe ITP. Second line, right, this is if that patient's not responding to these treatments, they continue to persist. Splenectomy, that spleen now is becoming, you have afunctional or functional asplenia, right? You have a spleen, but it's not doing anything anymore, it's just kind of enlarged and taking space. They may consider splenectomy. Monoclonal antibody is kind of a failure. If they fail IVIG, this would be considered by hematology. And there's thrombopoietin receptor agonists, right? But I don't really care if you know second line, just focus on the first line. What I do care about is this patient's requiring intervention, right? These are the emergencies. These are the ones that you can't, like, all right, well, I'm going to put a consult and see how it goes. These are patients you need to intervene quickly, right? So, low platelet count, less than 20,000, what are we going to do? Platelet transfusion, right? So it may say platelet transfusion, it may say a 6-pack of platelets. It just depends on how test questions are written for PANCE or my test. So don't get those confused. As long as it says platelets, that's what we're going for. And then treatment for the secondary causes at present. And then hopefully by now you've realized that hematology consultation is for all these patients. If I talked about hematology, for the most part, these are going to get, except for maybe some of our anemias, these should be going to hematology for a final check. All right, heparin-induced thrombocytopenia. So this one is kind of unique, is that it goes against normal thinking, right? If I say low platelet count, what am I thinking for a patient? What's that put an increased risk for? Bleeding. So this one's the exact opposite. You're going to see low platelet count, but it's actually causing clotting. Right? And this is a clinical diagnosis. So look at that vignette. The patient had exposure, they got administered heparin. 5 to 10 days after that heparin, they start developing clots. Right? So that doesn't really make sense because heparin's supposed to stop clots. And now we're seeing decreased platelet counts that should be increased bleeding, but in this case for HIT, specifically heparin-induced thrombocytopenia, this is causing clotting. So not dose-related, right? It could be just a flush for a heparin lock, line flushes, heparin-coated catheters. It doesn't have to be they got a massive amount of heparin over days. This could be a small amount. Typically, the more heparin they get, the higher likelihood they're going to have this. But it's at risk for both venous and arterial thrombosis. And then this hypercoagulable state persists for weeks to months after heparin is discontinued. So, typically, if they have diagnosed heparin-induced thrombocytopenia, they're never going to get heparin again, right? It's concerning that they're going to get this later on too as well. So that's going to go in their chart as they have a heparin sensitivity or a history of HIT. Now this happens as heparin binds with the platelet factor 4, triggers an autoimmune response in the formation of antibodies to heparin 4 complexes. These bind to the platelets. This activates the platelets leading to aggregation, right? So activation of platelets leads to more PF4 worsening the cycle. So what's happening now, platelets are going down 2 mechanisms. They're either being consumed into these clots into these thrombi, or the ones that aren't getting consumed into the thrombi are being identified and being removed by the spleen, right? So it's a double-edged sword of platelets start going down because one, the clot is consuming them, and then two, the ones that aren't getting consumed are getting identified and being removed by the spleen. So clinical presentation, right? 5 to 10 days after heparin, we see a platelet count drop of greater than 50%. We're thinking hit until proven otherwise. It's a clinical diagnosis. Again, 5 to 10 days, decline 50% or more. They may have these necrotic skin lesions at heparin injection sites. They may not. But they're going to have thrombosis associated with thrombocytopenia, right? All those clots and thrombi are just consuming those platelets, and the body can't replace them because any platelets that are not being consumed are being identified and removed by the spleen. So 4T score, I don't need you to memorize this, right? What I want you to get out of this is high or low, right? Low score, just like the Wells criteria, that's telling you it's less likely that they have heparin-induced thrombocytopenia. If it's high, I want you to think heparin-induced thrombocytopenia. Does that make sense? So don't memorize this chart, just know the scores, low 4T or high 4T, and what that's telling you. Confirmatory is going to be this heparin antibody, ELISA, right? That's going to confirm that we have this. But we don't need to wait for this confirmatory test. If that patient has that clinical index or clinical suspicion that they have it, they got administered heparin in the hospital 5 to 10 days ago, now they're blowing these clots and their platelets are going down, we're thinking hit until proven otherwise. Pretty straightforward management. We're going to DC that heparin as soon as possible, right? And they shouldn't be getting any more heparin in the future. We should avoid it unless that decision, if they're going to get heparin in the future, is going to be from hematology, right? Until hematology puts in the chart and says, yes, we tell you to get heparin, you avoid it the rest of the time for that patient. And then in this one, we're going to be getting a direct thrombin inhibitor. So we think heparin, right? What does heparin do? What is it? Why is it working? What does it initiate or help with clotting? Or stop clotting? So basically boost antithrombin, right? The stuff that breaks thrombin, that factor 2 in the common pathway. With the direct thrombin inhibitors, this is kind of like precision fire. It's basically taking out that thrombin. Instead of antithrombin, which works in a different effect, this is just stopping thrombin from propagating. So we're going to begin that direct thrombin inhibitor on this patient. Was this recovered to 100,000? Warfarin may be initiated. Again, this is going to be one of those things you need to consult with hematology. They're going to drive the train on hit. Typically, this patient's going to be inpatient the entire time while this is going on. Duplex Doppler ultrasound lower extremities to rule out subclinical DVT. Avoid platelet transfusion unless bleeding occurs, right? Until we have this hit regulated, there still could be circulating heparin that could be causing more issues with those platelets. So we want to avoid additional platelets unless they have active bleeding. And then anticoagulation, going to continue 3 to 6 months with documented thrombosis. Without documented thrombosis, 30 days. All patients with HIT should be evaluated by a hematologist. Right? Thrombotic microangiopathy. So think of this one as a mechanical disorder, right? So what's happening, small vessel injury, creating these microthrombi forming, platelet consumption, right? Those thrombi are consuming the platelets because it needs more of them. And then what's going to happen is you're going to have this hemolytic anemia because that microvasculature, there's these microthrombi, RBCs are trying to pass through, they're going to get sheared, and it's going to create these schistocytes, right? So if you think schistocytes, I want you to think TMA, thrombotic microangiopathy, right? Angiography. So what this is this kind of an umbrella term. The main types are going to be TTP and HUS. So TTP, we're thinking adults. This is going to be more neurological, brain affected. HUS, we're thinking pediatrics, and this is going to be more kidney focused. You can also have neurological findings with HUS as well, but overall, TTP is going to be neurologic adults, HUS is going to be kids, and it's going to be kidneys. But primary features of both those schistocytes, right? So in those small vasculature, you have these small clots, these microthrombi. RBCs are trying to pass by, there's not room, they're getting sheared off, and they're creating these remnants of these RBCs. So this is where you're going to see probably anemia on CBC, you're going to get a peripheral smear, and then this is where you're going to see those schistocytes. So schistocytes, until proven otherwise, we're thinking TMA. And then thrombocytopenia, right? So this is going to be, those platelets are being consumed by the thrombi. So you get that initial CBC, you see anemia, and then thrombocytopenia. We're thinking this, that we're going to get a peripheral smear. We're going to see those schistocytes, and that should be cluing us in on this patient. So kind of two ways is acquired or hereditary. Acquired, what is the ADAMTS13 deficiency? What is this doing? So this is the molecular scissors, right? So you have these large von Willebrand meat monomers. And what is von Willebrand? What is that doing again? Allowing the platelets to clump together, right? Create that platelet plug. This is basically giant von Willebrand factors, so they're consuming too much. Their arms are not getting cut down by this deficiency, so it's kind of running out of control. We think with TTPs, median age 40 years old, so adults, females are more likely, and then they're going to have these neurological findings: confusion, headaches, seizures, speech abnormalities, paresis, right? So think adults with neurological disorders, and then that CBC is going to have anemia, thrombocytopenia, get my peripheral smear, and I'm seeing schistocytes. They also see abdominal pain, nausea, vomiting, diarrhea. And then likely you're going to see bruising, petechiae, purpura, especially as that platelet count drops. So anemia, what type of anemia are we thinking? Microcytic, normocytic, macrocytic? Likely to be normocytic, right? Because there's nothing actually happening to the RBC size itself. You may see macrocytic with increased reticulocyte count on the CBC, but peripheral smear will differentiate that for us. Hemolysis testing is showing us that you're seeing the destruction of those RBCs that are getting sheared in the microvasculature. Key diagnostic feature for this is those schistocytes, right? Typically normal PT, PTT, there's not anything going on with the bleeding, it's just a platelet disorder. Coombs test negative, rule out those antibodies. Urinalysis, you may see some blood in there, some protein. And then at Adams C3, TS13 assay, which is going to be diagnostic for that acquired. The key treatment for this is going to be that therapeutic plasma exchange, right? So plasma exchange is what? I pull out the bad plasma and I replace it with good plasma. So that's a key treatment for this, therapeutic plasma exchange. What's the key treatment for TTP? Therapeutic plasma exchange. Y'all get what I'm putting down? Gotcha. Right. So now HUS, we're thinking pediatric patient. We're thinking this is going to be kidney, right? There can also be neurological findings, but this is more so kidney. So same concept, you're having that hemolytic anemia comes from that microthrombi in there, thrombocytopenia from the consumption of platelets, which is then causing this acute kidney injury. So this is almost always caused by gigatoxin producing E. coli. I added where you're going to see likely, so if you see a vignette, it's going to be undercooked ground beef, pasteurized milk, unpasteurized milk with contaminated water. And this follows a typical kind of timeline, so think child, pre-existing, they may have had a history of diarrhea, abdominal pain. 5 to 10 days following that infection with E. coli, bloody diarrhea, vomiting, dehydration. You would think hypotension associated with this, but typically it's hypertension associated because now it's affecting the kidneys. Lethargic, abdominal pain, pallor. You may see hematuria, urea, right? Some blood in that urine. Rash, easy bruising, and then CNS involvement. This timeline is showing you this is their ingestion. Negative day 3, day 0. They start getting the symptoms, right? It progresses. You may get a positive culture on them after day 3, and then they're usually going to resolve. So 80 to 85% spontaneous resolution, no long-term effects. We don't need to do anything further. 15% are going to turn into HUS, but it's going to be ongoing. So same thing, you're going to see anemia because you're having all those RBCs getting destroyed. So you're going to see evidence of hemolysis as well from those sheared RBCs, which are going to be appearing as schistocytes on the peripheral smear, those remnants of the RBCs. Hemolysis labs are going to be showing that there's destruction of RBCs. Again, the coag study should be normal. Coombs test negative. But now we're starting to see that kidney effects, so increased BU and creatinine. What else? Decreased GFR. They see blood in their urine, protein as well. Another test that's specific for this one is going to be that stool culture for Shiga toxin. All right, so essentially what happens is they ingest that food, E. coli goes in the gut, that toxin comes out and it travels down to the kidneys and initiates this. You get that platelet consumption is small, thrombi in the microvasculature, consuming platelets, and then RBCs are trying to pass through the microvasculature, they get sheared off and you get these schistocytes. Typically, if the patient is stable, right, again, stable, patient can not have any red flags, hospitalization and IV fluid therapy. Remember, majority of these are going to be spontaneous resolution. Some, 15%, may require blood transfusions and dialysis if it's severe, right? If their body's not doing what it needs to do. Potentially harmful interventions that we could be causing, antibiotics, put more stress on the kidneys. Anti-motility agents, right? We don't want to give them what? What's that medicine that we stop when we stop diarrhea? Loperamide, what's the other name for that? Imodium, right? So we want all that badness to pass through. We want them to continue to have the diarrhea as long as we're hydrating them. And then NSAIDs can also, depending on where they're metabolized, can affect the kidneys. And we're not going to concern about atypical HUS. That's a whole other discussion. All right, acquired platelet disorders. Uremia, what's uremia going to be caused by? Bad liver, bad kidneys, right? Kidney disease, kidney injury, right? Those toxins impair platelet function. Drugs that we talked about, right? Aspirin, NSAIDs, these things that are anti-clotting that patients take. And these myeloproliferative disorders, things that are going to be impacting their ability to create more, right? So bone marrow, certain cancers. With this one, mucosal bleeding despite normal platelet count. So now this is where we're talking about, we got a CBC, it was completely normal, but the patient's having signs and symptoms of some bleeding disorder. This is where we're going to go to that other pathway because now we have a higher index of suspicion because that initial CBC was normal. So now we're concerned about something with the platelet itself or something that's impacting the platelet. So uremia, can do dialysis, desmopressin, drugs, just continue those offending agents, get them off aspirin, NSAIDs. Myeloproliferative disorders, we're going to treat the underlying disease. So I added on here secondary to kidney disease or injury, so you understand that vignette, right? Is if they have underlying kidney injury, kidney disease, those labs are supporting it, that can cause this uremic type environment, that's going to impair our platelet function. Clinical presentation is mucosal bleeding, easy bruising. Diagnosis, platelet function test. So they put plates in there, they don't aggregate, they're not actually doing what they're supposed to be doing. Prolonged bleeding time, and then elevated BU and creatinine is pointing towards kidney disease. Again, just like I said before, dialysis, desmopressin. All right, drug-induced platelet dysfunction, pretty straightforward, these medications that we've talked about. You can also be concerned about certain antibiotics as well. So these medications are going to impair the platelet function or identify them for destruction caused by certain medications. Just like before, clinical presentation, mucosal bleeding, easy bruising. CBC, again, is going to be normal. That peripheral smear is going to be normal. Normal bleeding test, typically a clinical diagnosis. So this is where we get into that discussion with our patient and we make sure to see clarify what medications they're taking, either over the counter or prescribed. Just continue that offending drug and platelet transfusion if necessary. Myeloproliferative disorders, so it's clonal disorders of hematopoietic stem cells can affect platelet function, right? Adequate number of platelets, right? So this is a qualitative disorder, not a quantitative. The platelet normal, but they have abnormalities from clonal proliferation, right? They're created abnormal. Thrombosis or bleeding, depending on specific disorder. Typically, this is going to be more of a pronounced, more advanced than the other two that we talked about. This is going to have a more specific or more severe clinical presentation. Our diagnosis, CBC, should be normal. Peripheral smear should be normal. Bone marrow biopsy is what's going to probably clue us in to actually get the diagnosis for this one. And treat the underlying disease. All right, any questions? All right, so we can do part of the review right now. I have some test questions that we can go over to kind of get your mind primed about these tests. So to be successful, think about the clinical presentation, think about the lab support. This is going to be a very lab-heavy test. I'll tell you the labs are not going to be this straightforward on the test. They're going to be more advanced. I'm going to give you an entire CBC. I'm not just going to say hemoglobin MCV. Kind of giving you a softball here to keep trying. Look at that, suspect the disorder or the underlying disease, and then know the next steps in evaluation and treatment. It's kind of a pathology question. This was in the beginning. All right, what are we thinking? What? Somebody said something. D? You think a D? All right, what stands out to you in that vignette? So rheumatoid arthritis, right? Is that a chronic disease? Okay. What else? Is he symptomatic? Yeah, fatigue, generalized weakness. Does that really point you in the direction of any one specific disorder? Almost every patient that we've talked about so far has had the generic symptoms, right? What about our labs? Is that hemoglobin low or high? It's low, right? And then our MCV, is that microcytic, normocytic, macrocytic? Microcytic, right? And then serum iron's low. You gotta start putting this together, right? So your TIVC is low too. Ferritin's high. So what are we taking on this answer? All right, D. Anybody disagree? What did you say? C? All right. Anybody disagree? D or C? All right, it's going to be D, right? Remember hepcidin with inflammation? It's going to reduce our iron availability. So if inflammation goes up, right? Hepcidin goes up and decreases our iron availability. So things that stood out to me in this, all those labs were abnormal. Chronic disease and the persistent fatigue and generalized weakness is pointing me towards anemia. Right? And then there's the lots that we talked about right there. Right? Sit it in, iron availability. What's that? All right, so what are we thinking? Before we even get to the answer, what stands out to us in this question?
Neuro.
First off, let's just start from the beginning, right? 78-year-old male, right? 9-month history of progressive fatigue, forgetfulness, and pins and needle sensation. What's that pins and needle sensation pointing towards? B12, right? Is that microcytic, macrocytic, normocytic? Macrocytic, right? Does that MCV support that?
Yep.
Yeah. Does the 9-month history support that? So we talked about how long does it take you to deplete your vitamin B12 stores? Months to years, right? And then how long for your folate? Weeks to months, right? What else is going on there? Cognitive function, right? It has those neuropsychiatric effects. And then what else? Physical exam, pale skin, that would be just about any anemia, right? Smooth, beefy red tongue. What's the other term for that? Myositis, right? Is it only going to be in this? Could I see that in other type of anemias or other disorders? Yeah, so that's not a necessarily a key characteristic, but it's supporting our diagnosis or what we're thinking, right? And it demonstrates an unsteady wide-base gait. Remember I talked about it? At that hemp block, not or veteran, they just have the vitamin B12 deficiency, right? So we've talked about vitamin B12 historically can be all over the place. It's not the most reliable test. So there's two that help us differentiate our MMA and homocysteine, right? So what is our answer? B? Is that what everybody said? It's going to be B, right? So again, we talked about all this. We're seeing all those neuro symptoms right here, pointing us towards that. It's a 9-month history. Macrocytic anemia. So we talked about macrocytic anemia, right? I want you to think it's either megaloblastic or non-megaloblastic, right? We're always thinking it's going to be B12 or folate until proven otherwise, right? Those are going to be the two most common. If we get our B12, folate, MMA, homocysteine, and they're all normal, then we can go to another pathway and think maybe one of the other ones. But we're always taking B12, folate. Yeah.
Why would D be wrong with the low folate? Do they just not both go down, or can they not be both low?
Because this is specifically vitamin B12 deficiency. We talked about it. If you look at the slide, you can have combined B12 and folate deficiency. So, I mean, could it be? Yes, but for our collection purposes, yeah. You guys are already starting to approach us about test questions.
You're ready for surgery.
Yeah. That peripheral smear too, hypersegmented neutrophils, that is helping us with that vitamin B12 as well. Boom. Right. All right, so what are the things that stand out to us?
Everything's low.
Everything, right? Let's look at that profound fatigue, multiple episodes, and separate bacterial skin infections. So profound fatigue, what are we thinking? Which one of those cell lines? They're going to be what? But what specific of the 3 cells that come off that stem cell line? Fatigue is going to be more associated with platelets, RBCs, white blood cells. RBCs, right? You're thinking anemia, it's fatigue. That multiple episodes of epistaxis, nosebleeds, what is that going to be? Platelets, right? And then bacterial skin infections, white blood cells. They don't have a competent immune system, right? So I want you to look at that vignette before you even get down to the labs, right? And the labs should be supporting or ruling out your diagnosis, right? That's the purpose of labs. So we got all that. I'm thinking maybe there's some pancytopenia going on right now, right? Widespread petechiae in his lower extremities and pale mucous membrane. So what is that widespread petechiae pointing towards? You're creating thrombocytopenia, right? That's pointing towards that petechiae. They're having that bleeding. And then pale mucous membranes is pointing towards what? Anemia, they don't have enough hemoglobin, right? Those RBCs aren't carrying enough of that. So now we get our CBC, right? White blood cells count are low, right? That's supporting our bacterial skin infections. Hemoglobin is low, that's supporting our profound fatigue and our pale mucous membranes. Platelets are low, which is supporting our recurrent nosebleeds and that petechiae in his lower extremities. So again, real world too, well, look at the patient, clinical presentation. Your lab should be supporting your diagnosis or ruling out that something else, right? So that's why we don't shotgun labs. Critical thinking, put it all together. And then that reticulocyte count is markedly low. What is that telling you?
Bone marrow is not functioning.
So it's telling you the bone marrow failure, right? Is that the bone marrow is not picking up compensation. So if this patient continued, what else would I probably expect to see if the bone marrow is failing?
Liver.
What would start to try to kick in to compensate?
Liver and spleen.
Right? So you can see spleen enlargement, liver enlargement, I'm sorry, spleen enlargement, liver enlargement, they're somewhere in the abdomen, whatever. What else could be enlarged? What else will help with creating these to a lesser degree? Lymph nodes as well can start kicking in, right? That immune system. So you may see a little bit of lymph node enlargement, right? So what is going to be confirming our diagnosis? Bone marrow biopsy. Right? So just everything we've talked about, right? Think of that clinical vignette. Your lab should be supporting what you're thinking of or ruling out, right? It shouldn't just be shotgunning labs. Okay, classic anemia. All right, so before we even look at those labs, let's look at that clinical vignette. What is standing out to us? Lifelong history, right? This isn't just a one-time thing, this is lifelong. History of easy bruising and frequent prolonged nosebleeds, what is that, what are we thinking right there? Something's going on with the platelets, right? So if I got a CBC, I should be expecting to see what?
Low platelets.
Thrombocytopenia, low platelets. There are also reports menstrual periods are excessively heavy, requiring her to change pads every few hours for the first days, right? Real world guys will never figure this out. Like, they won't put it together, I promise you. Women will understand it, and they'll be like, oh, that makes sense. Guys will be like, I don't know how many pads a woman uses. 8 a day? Is that normal? Whatever. So you gotta understand that stuff and ask these questions. Is that more so than normal? Go to the office next door or the female provider, like, hey, how many pads should a woman be using to get clarification? I never put that together when I was practicing. Physical exam is noted for ecchymosis on her arms and legs, but no petechiae, right? And what about her labs? Anything standing out to you?
Just prolonged bleeding time.
PTT slightly prolonged, and the bleeding time's prolonged. So what is the bleeding disorder that we're thinking about? Boom. Right, so we talked about that. That's one of those diagnostic features of that is normal or slightly prolonged. But the history, the vignette in this case is kind of giving you the diagnosis, what to be pointing towards. All right, so what stands out to you?
5 days. 5 days after.
So warfarin, right? For newly dosed, for like 5 days after starting warfarin, what else would I want to see? I can't really say yes or no in this with this vignette, but what should I hopefully be seeing as well with that warfarin when it was started 5 days ago? Heparin should have been started too as well with this patient, right? Because we need that work with that heparin bridge. We don't want to just give warfarin because what does warfarin do? What is the role of warfarin? Stops the new what stuff? What's the stuff? I need you to get a little bit more clinical than stuff. I don't know if they say they don't like stuff. What kind of dependent factors?
Vitamin K.
Does it do anything to the current circulating factors? No, so that's why you're explaining that heparin bridge, right? And then how does heparin work? What does it do to antithrombin? Boosts it, right? It accelerates it. It says, antithrombin, I got your back. We're going to mess up some stuff with lupus, right? So, talk about that vitamin K. So, which now is it going on in here? What's the answer? C? You don't think E?
No, that's just the buddy.
What's that?
It's just the buddy.
E's the buddy?
Oh, that's S. S.
Yeah, man, see, you fell for it right there. That's why there's always one. All right? There's going to be at least one test question on here with something you've never seen before, and one of y'all going to pick it. It happens every time. 100% that's the pick, right? So factor 2, 7, and 9, we would think of these as accelerators in the clotting cascade, right? Protein C, we're thinking of that brake. And then protein G, what does protein G do? I don't even know if there's a protein G. I just made it up. I put a letter in there to screw with you guys, and one of you fell for it. So, boom, I got you. Right? But if that was protein C or S, which one of those proteins is more important? C, right? I think S is the little buddy that's helping you out. Like, I got you, pal. The protein C is like the big one. Here's the last one. All right, so let's look at that vignette before we even look at the labs. What is that vignette telling you? Things that stand out to me, right? 3-day history. So is this acute or chronic process? Acute process, right? It even says new onset of rash on our lower legs and easy growing. What do we think of that rash when the patient's saying that? Is that truly like a dermatological rash? Right? Patients are going to say, I have a lesion. They're going to say that shit all the time. You're like, oh, okay, cool. Or I have a rash, right? It's not really a typical rash. Maybe it's something else. Then we start going down, bleeding gums, when she brushes her teeth. What are we thinking right there? Something's going on with the platelets, right? Or they just have really bad hygiene, right? No other symptoms than IV, recent illness or new medications. There's that rash, that widespread petechiae, right? Which is partly due to what? Again, that's supporting that there's low what? Low platelets, right? So again, look at your clinical vignette. Your lab should be supporting your suspicion or ruling out. There's no splenomegaly, right? And that would make sense because this is acute onset, right? If this is chronic, I may start to see splenomegaly, but typically the splene's not going to be enlarged in a matter of 3 days. Now we look at our labs at CBC. Not really anything that's pointing towards an infectious purpose, right? The white WBCs, I should be expecting that to be normal. Hemoglobin, again, patient's not complaining of what? Patient's not complaining of fatigue, decreased energy, any of that stuff. And what's in physical exam findings should I expect to see if I have a patient with low RBCs? Pale, pallor, right? Mucous membranes. Platelet count, is that low? It's extremely low, right? This is that one in the ER, goes, oh shit, what's going on here? Shows a peripheral smear, reduced number of platelets, but their normal morphology, RBCs, and white blood cell morphology are unremarkable, which helps support it, that makes sense. Because if this is low, what else could this be? Say my patient's presentation is completely normal, they have nothing, and I have this low platelet, what else could that be? Pseudothrombocytopenia. So that would be the indication of why I got this peripheral smear, right? Without that, peripheral smear is going to tell me is this true thrombocytopenia or pseudothrombocytopenia. So what is this most consistent with? If I told you there's isolated thrombocytopenia, what to assume until proven otherwise? D, immune thrombocytopenia. Right? All right, any questions on that?
The
Um,
other one-
So here's the deal, we could start the review now, but if we don't get done in 30 minutes, it's up to you guys. The review is just gonna be a discussion. Is there anything recording right now? Turn that off for me. I'm not doing anything like shady or shit, man, I'm not that